Good morning, afternoon, and evening. Welcome to today's Vermont Oxford Network Grand Rounds on the evidence to practice preventing hypothermia. I'm Danielle Arrett, the Asfa Yamaru Green and Gold Professor of Global Health at the University of Vermont and Chief Medical Officer and Director of Global Health at Vermont Oxford Network. I'll be moderating today with Professor Roger SOLL, the H. Wallace Professor of Neonatology at the University of Vermont, Coordinating Editor of Cochrane Neonatal, and the Director of Vaughan's Institute of Evidence-Based Practice. Today we have two discussants, Dr. Elizabeth Foglia, Associate Professor of Pediatrics at the University of Pennsylvania School of Medicine, and Dr. Erica Edwards, Research Professor at the University of Vermont and Vermont Oxford Network's Chief Scientific Officer. The sponsor for today's session is Vermont Oxford Network and the Vaughan's Institute for Evidence-Based Practice. Here are our disclosures as they relate to today's topic. To participate in today's webinar, we encourage you to chat questions and comments to everybody during the presentation and in the discussion. We'll have some time at the end for question and answer, and we'll also have several polls using the Zoom platform. To participate in those, we ask you to select your answers and click the submit button. Those answers will be able to be aggregated and we'll see the results together. Unfortunately, any answers in the chat will not be able to be included in those responses. So to give practice and set the stage for our discussion later today, we'd like to start with asking you about guidelines on this topic. Do you have written guidelines that address the prevention of hypothermia in delivery room resuscitation? This is a check all that apply type of question. So you can click yes in term infants, or both yes in term and preterm infants, or however is appropriate for your setting, or no, we do not have written guidelines for the prevention of hypothermia in the delivery room. Once you've clicked your answer, please hit submit. And as a reminder, nothing in the chat will be able to be shown to everyone. So please use the Zoom poll, and we are excited to see how that pans out. I don't quite see the answer, but we'll think about that and as consider how you're answering personally. Is there an opportunity for improvement, or is this something that your team has already decided and is already underway? I think to inform those guidelines that teams have been putting together, we're going to turn it over to Professor Roger SOLL to review the evidence behind these guideline development, particular to preventing hypothermia. Over to you, Roger.
Thanks, Danielle. Today, we're going to discuss the evidence available to help us make informed decisions regarding the prevention of hypothermia in preterm infants. Specifically, I'd like to focus on what are our goals, and does preventing hypothermia make a difference to preterm infants? Let's discuss in the most general terms. Abnormal temperature is unfortunately very common amongst preterm infants after birth. And the current guidelines recommend a combination of therapies to prevent heat loss, which we'll go through today. But despite the available evidence, abnormal temperature is still a problem across all climates, in all settings, and in all economies. For this talk, I'll draw on several different articles that I'll highlight. Here, a nice review from Neo Reviews regarding thermoregulation and advances in the preterm infant, which gives a very good review of the physiology regarding hypothermia. Let's start with some of the obvious facts. Newborns undergo many adaptations after delivery to adjust to extrauterine life. One of the paramount adjustments is the need to rapidly increase body temperature to accommodate to an environment much colder than the one in the prenatal milieu. The temperature of the fetus is slightly above maternal temperature by about half a degree, but within a few minutes after birth, neonatal core temperature begins to fall precipitously. So keeping babies warm, particularly preterm infants, can be challenging. Compared to term infants, preterm infants are at higher risk for hypothermia because of several unique characteristics. They can only maintain their core temperature in a very narrow range of environmental temperatures. They have a much greater skin surface to body weight ratio, leading to more radiant heat loss and eventually more insensible water losses. And thermogenesis is compromised. Brown fat is not well developed until well into 26 to 30 weeks gestation. Interestingly, this issue of hypothermia is really at the core of our history of modern neonatology. William Silverman, a pioneer in the field of modern neonatology, made the observation that there was more significant mortality amongst low birth weight infants who were hypothermic on admission to the nursery and in the first few days of life. And in trials, he noted a striking improvement in survival rate of infants who were cared for in warm environments, particularly in the first 5 days of life. So, what in fact is hypothermia? Well, here is the WHO definitions, and our eye initially is attracted to the very narrow range of what is normothermia, 36.5 degrees centigrade to 37.5 degrees centigrade. Somewhat cooler, at 36 degrees to 36.4 degrees, we consider the infant experiencing cold stress. But if it's much cooler, 32 degrees to 35.9 degrees centigrade, the infant has moderate hypothermia, and less than 32 degrees is severe hypothermia. We also have to take note, and we'll mention in this discussion, some of the complications of the other side of the equation, namely hyperthermia, temperatures greater than 37.5. Since Bill Silverman's observations in the 1950s, there is a plethora of literature suggesting that admission temperature is an extremely important predictor for morbidity and mortality. And here is some work from the Neonatal Research Network that makes this point. In this review of infants between 2002 and 2003, these very low birth weight infants had data collected regarding birth variables, admission weights, and clinical outcome. You can see here that the categories that were used in this report don't exactly correspond to the categories suggested by the WHO, but only around 42% were in the normothermic range, with a significant number of infants being hypothermic and close to 1 in 10 being hyperthermic. Importantly, the authors noted that even in an adjusted analysis, admission temperature was inversely related to such important outcomes as mortality, with a 28% increase per 1 degree centigrade decrease in core body temperature and late onset sepsis, but not related to some other complications of prematurity, including intraventricular hemorrhage, neck, or the need for conventional ventilation. So let me take you for a few minutes back to the classroom, to something we all studied all through school. We study in NPR, in NRP, and that is, what are the mechanisms of heat loss? And we think of 4 key mechanisms. We think of convection, evaporation, radiation, and conduction. And let's take a second to define each of those. Evaporation is one of the most major sources of heat loss. Water loss can occur through the skin, and we're used to thinking about that, but also occurs through the respiratory tract, particularly in babies who have respiratory distress and higher respiratory rates. Through their immature skin, there's more heat loss and more evaporation. At birth, a baby is wet and there's a dramatic temperature drop. And this temperature drop is related both to temperature and to humidity. Evaporative losses can be enormous and may total up to 200 kilocalories per kilo per minute. Think about that when we think about how difficult it is to deliver that nutritionally to our babies in the days after birth. Convection is another source of heat loss. Heat is transferred by convection when air currents carry heat away from the body surface. So really, this is any place where a baby is left that is drafty, by an open door, by a vent, by air conditioning units. And we do try to counter much of this by leaving babies in beds that have raised sides or incubators, and we'll discuss that when we discuss interventions. Conductive heat loss is a very direct heat loss. It's when heat is lost from the baby coming into direct contact with a cold surface or object, for example, a cold blanket. And this can be minimized by pre-warming surfaces or fluids and preventing this sort of very direct heat loss. And then the one heat loss that's hard for us to understand and quantify, and that's radiant heat loss. All body surfaces emit heat energy in the form of electromagnetic waves, so-called radiant heat. And it's hard for us to think that you could be losing heat to a cold wall that is feet away from you or a window located nearby. But it's very easy for us to think of how we can supply energy to a baby through something like a radiant warmer, which is the opposite of this heat loss. So let's see how this plays out in practice. What do we know from trials regarding strategies to prevent hypothermia in the delivery room? I'll rely on at least 3 different sources for the evidence that we'll present today. One is the narrative review of Dunn and colleagues looking at thermoregulation for very preterm infants in the delivery room. The second is the ILCOR COSTAR statements that update their general delivery room recommendations. These aren't as easy to come by, but can be found on the web at the web address on the slides. In this exercise, the crew at ILCOR tried to update their recommendations, specifically focusing on preterm infants and looking at a variety of heat loss prevention strategies. They classified their outcomes as critical, such as survival, and important, such as rates of normothermia and hypothermia. I'll also be addressing a large blanket review of McCall and colleagues that looked at general interventions to prevent hypothermia at birth in preterm or low birth weight infants. There were 15 different comparisons in this group, and we'll only select a few of them for discussion today. So, there are multiple strategies in which we can improve thermoregulation, some of them pictured here in this figure from Dunn and colleagues. They can be simply grouped into strategies that use an external heat source and strategies that prevent hypothermia. And we'll start with the strategies that use an external heat source: delivery room temperature, radiant heat, use of a thermal mattress, skin-to-skin care, and the use of heated, humidified gases. And we'll begin in the delivery room, which is probably the most obvious place to start. It's clear delivery rooms are kept at temperatures that are comfortable for us, for mothers who are delivering, and we're not thinking about the baby. It's clearly an environment where the baby will suffer. Cold delivery rooms maintained at temperatures less than 26 degrees centigrade, which is actually a pretty high cut point, have been associated with colder admissions to the NICU for ELBW, and raising delivery room temperature may be one of the most direct ways that hypothermia and cold stress can be addressed. One of the principles to think about in terms of this environment is the idea of the neutral thermal environment. The neutral thermal environment has been defined as the environmental conditions where the infant's temperature is maintained so that metabolic demands are at a minimum. There's minimal oxygen consumption and minimal energy expenditure. It's not one fixed range, but varies with the age of the newborn, gestational age, and birth weight. The neutral thermal environment is best achieved when an infant can maintain a core temperature between 36.5 and 37.5, our definition for normothermia. When we get into temperatures above or below the neutral thermal environment, we get into metabolic complications. Metabolic demands increase, the need for oxygen increases, and a vicious cycle begins, which can lead to acidosis, exhaustion, and other problems. Here, if we just focus at the central part in green where the arrow is pointed to, we see there is a very narrow neutral thermal environment, which actually is just a little bit below the infant's body temperature. And we see that when we either exceed it or we go below it, that there are serious consequences in terms of metabolic rate and ultimately clinical outcome. So what do we know about trials that have looked at delivery room temperature? Well, Dawson and colleagues in their COSTAR statement identify 5 trials. 2 are randomized trials and 3 are observational studies. And in this case, I'll show you not each individual outcome, but the comparisons of warmer and colder delivery rooms. They use the cut point of 23 degrees centigrade to differentiate what was a lower or a higher temperature. And on your left, you see the various comparisons. In each case, a warmer delivery room temperature led to improved body temperature, sometimes by approximately half a degree centigrade. It reduced moderate hypothermia and wound up with a number needed to treat to improve the risk of hypothermia being anywhere from 6 infants to almost 900 infants. So what about some of the basic ways that we care for infants in terms of where we place them for care, the incubator or the radiant warmer? Perhaps nothing besides the ventilator symbolizes the advances in neonatology as much as the incubator does. The trials of using incubators are old, historic, and small, and they involve rather simple comparisons. Here is a comparison looking at double wall versus single wall incubators and reducing heat loss. You can see that there are a tiny number of trials, 3 trials, 33 infants, and these trials were all done decades ago. Double wall incubators did demonstrate decreased heat loss, decreased heat production, decreased radiant heat loss when compared to single wall ventilators, and also have the advantage of reducing oxygen consumption. All of these effects are small. None of them translated into long-term effects, but clearly this is now the type of incubator that is routinely used. There are also trials that looked at the use of radiant warmers versus incubators for regulating body temperature. Again, a small number of trials, 8 trials, involving an even smaller number of infants, 175 infants. In this case, in the 8 trials, the radiant warmers caused an increase in insensible water loss and a trend towards increased oxygen consumption, which was not statistically significant. Due to the very small numbers of these trials, few clinical differences can be addressed. Nowadays, we are very aware of the fact that the radiant warmer is not a long-term place to care for an infant. And if an infant is in a radiant warmer, we're aware that we need to account for the insensible water loss that is associated with that form of care. So there are some interventions which are more direct and probably more efficacious than these general ones of the incubator, and that is using thermal mattresses to keep babies warm. Again, I'll refer to Dawson's work published in the ILCOR COSTAR of 6 trials, 2 randomized controlled trials, and 4 observational studies. In this table, we take a look at various outcomes, some critical and some important, and we can see that there are some advantages to the use of the thermal mattress. In terms of survival, only 2 randomized controlled trials and 174 infants addressed this, and there was no difference in the rate of survival of infants cared for on a thermal mattress or otherwise. There were more infants who were normothermic on admission, with an almost 50% increase in normothermia in general. Mean body temperature was increased by about half a degree centigrade. But interestingly and importantly, hyperthermia was also increased. And this was evident both in the 2 randomized controlled trials, where there was a relative risk of 2.77, and in the observational studies, where there was almost an over 3-fold increase in the risk of hyperthermia. This needs to be kept in mind as a balancing measure in all of the work that we do when it comes to the thermal environment. People have asked about the issue of skin-to-skin care, and skin-to-skin care is very important in the care of the low birth weight infant, but it may not be as adequate for initial temperature control as one might hope. The title of this systematic review by Gupta and colleagues pretty much says it all. Systematic review confirms the benefits of early skin-to-skin care, which include issues such as better maternal bonding and better breastfeeding, but really don't address the issue of temperature control. They reviewed 30 studies, of which only 8 focused on the preterm infants. And although they found the benefits of skin-to-skin care that had been reported in many places, they did not find a benefit on temperature control and argued that this should be further evaluated. The use of heated, humidified gases is something that we don't always think about when it comes to temperature control. But in fact, there are 2 trials involving 476 infants that address this point. In terms of survival, the most critical outcome, there is no difference that is shown with a relative risk of 1. Normothermia is also similar in the 2 groups, but mean body temperature was increased, and there is a decrease in moderate hypothermia associated with the use of heated, humidified gases. Of note, there was a decrease in the risk of intraventricular hemorrhage, which is not necessarily, it may be just a random effect or may be related to these issues regarding temperature control. Other interventions to prevent heat loss, not to give energy and heat energy to the babies, include the use of polyethylene bags and the use of hats or other head coverings. Let me start with the evidence around occlusive wraps, because that's perhaps the most extensively studied intervention for preventing hypothermia in preterm infants. Placing or covering an infant with an occlusive wrap immediately after birth will reduce the incidence of hypothermia and result in decreased morbidity and mortality. There are lots of different bags that have been used, as complicated as gastroschisis bags, and as simple as going down to the grocery store and getting some of the plastic wraps there, a common practice in the UK. Some of the initial work from Robin Noble and her colleagues showed that the admission temperature of infants who were placed in polyethylene bags was clearly higher than those infants who were not treated with wrapping. Towards that end, Maureen Riley, Sunita Vora, and colleagues took a look at a larger trial of heat loss prevention with hopes to see larger downstream influence regarding clinical outcomes. This trial was done in infants 24 to 27 plus 6 weeks gestation, who were enrolled prior to delivery and randomly assigned to occlusive wrap or no wrap, with a primary outcome of all-cause mortality. So wanting to see whether or not these improvements in baseline temperature on admission translated into major improvements downstream. Over 800 infants were enrolled, and there was no real difference in baseline population characteristics. There was, as predicted by the smaller trials, a statistically significant higher baseline temperature in the infants who were wrapped compared to those who did not receive wrapping. However, there was no difference seen in mortality at hospital discharge. So application of the occlusive wrap in this trial did improve the rates of hypothermia, but did not translate into reduced mortality or other complications of prematurity. Now, that's the largest trial, but there are many other trials that have been done, and let's take a look at them in that context. Overall, there are 13 trials that McCall includes in her review of various interventions to prevent hypothermia, involving over 1,600 infants. Here's a look at the forest plot. On top, you can see the trials of all preterm infants. We'll look at those first. There are 11 trials that they report, and there is a significant decrease in the risk of hypothermia, defined either as a core body temperature of less than 36.5 or a skin temperature of less than 36. And when we see just restricted to babies less than 28 weeks gestation, we see that there is a similar decrease by 30% of the risk of hypothermia. The mean difference in temperature in this meta-analysis was 0.58 degrees centigrade, with a very narrow range suggesting there's at least half a degree centigrade improvement in body temperature. Hypothermia was significantly reduced with a RR of 0.67 and a point estimate for the RD of minus 25%. That translates to a number to treat for an additional benefit of only 4 infants and a very narrow confidence interval, saying that for every 4 or 5 infants we treat with plastic wrap, there'll be 1 less infant who presents with hypothermia. However, not dissimilar to the work that we looked at on thermal mattresses, there is a risk of hyperthermia. There is a almost 3 to 4-fold increase of the risk of hyperthermia. Because it is relatively rare, that translates to a RD of 4, suggesting that the number needed to harm is 25, a much larger number than the number needed to benefit. One might say that for every 25 infants we treat with plastic wrap, 4 or 5 of them don't have hypothermia, but 1 of them will have hyperthermia. As was seen with the Riley trial, when we look at all 10 trials of 1,447 infants, there is no difference that was seen in mortality. Here, looking at the forest plot, and we can see that in all gestations, as well as in preterm infants, we don't see any impact on mortality. In preterm infants, the relative risk is 0.92, but the confidence interval ranges from 0.72 to 1.18. The idea of wrapping babies, though, given the short-term but important outcome of increasing normothermia, decreasing hypothermia, has been well accepted. And here is a very nice summary of the results published by the National Perinatal Epidemiology Unit. So for the babies we wrap, we can expect over half a degree centigrade warmer body temperature. 50 will experience hypothermia compared to 74. But 5 will be overly warmed compared to 1 if not treated. Now, that is good evidence for the use of polyethylene bags. It certainly supports a decrease in hypothermia and does not suggest significant harms. But there's some interesting work. Here's some work from Dunn and colleagues reminding us that care in the delivery room changes and our procedures change. And they wanted to look at this whole issue of delayed cord clamping and when, in fact, you should wrap or not wrap the baby, now that there are competing activities going on in the delivery room. So they did a randomized controlled trial of babies less than 32 weeks gestation, who were randomly assigned to have the polyethylene bags placed before or after cord clamping. And in this study of just shy of 200 infants, they saw no differences in rectal admission temperature and no differences in death before discharge, a more important downstream outcome. They note that placing a plastic bag before cord clamping did not increase the proportion of preterm infants with normal temperatures on NICU admissions, and note that despite all of these efforts in both groups, there's a large proportion of infants with abnormal temperature. When it comes to some of the other barriers to heat loss, they're better studied in term babies than in preterm babies. Use of a plastic cap. They note that placing a plastic bag before cord clamping did not increase the proportion of preterm infants with normal temperatures on NICU admissions, and note that despite all of these efforts in both groups, there's a large proportion of infants with abnormal temperature. When it comes to some of the other barriers to heat loss, they're better studied in term babies than in preterm babies. Use of a plastic cap in babies less than 34 weeks gestation was only addressed in one randomized trial involving 64 infants. There was an increase in normothermic infants associated with the use of the plastic cap and a higher mean body temperature, and fewer infants with hypothermia or cold stress. So they're another very simple intervention that any skier will tell you is something that will keep you warm. Wear a cap. So let's wrap up with the idea of what can we do in our practices, and will quality improvement impact on delivery room hypothermia? And I'll just share with you one example from the group in Albany of how they tackled this issue. So they did a quality improvement project that was aimed at looking at admission temperatures and increasing admission temperatures in the target range of 36 degrees centigrade to 38 degrees centigrade. They did it over 60 months using a sequential plan, do, study, act cycle. During the 14 baseline months, they standardized temperature measurements and developed what they call the Operation Toasty Tot Thermoregulation Bundle. They introduced this bundle and then followed the infants and provided feedback using simple graphic and control charts. Here's a look at some of the simple things that they included in their best practices. To decrease conduction loss, they turned on the radiant warmer prior to delivery and made sure that it was warm, made sure that blankets were pre-warmed. They positioned themselves so as to not block the infant's access to heat. And they set up servo-controlled warmers to 37 degrees centigrade. For evaporative losses, they blotted off extra blood and fluid. They applied a plastic wrap and the important downstream outcome cap to these babies. And they did all their examinations and evaluations through the plastic wrap. And in terms of convection, they did turn up the temperature in their delivery room, and they really took a close look at the delivery environment regarding drafts and other sources of convective heat loss. They studied 164 very low birth weight infants. They noted that there was an improvement in baseline temperature that occurred with their intervention, and that the thermoregulation bundle resulted in a sustained improvement in normothermia rates. And so improvement certainly is achievable. I'll end this talk just with one caution, and that is that constant monitoring of temperature for all of these interventions is essential because there are possible harms. Certainly, there have been many reports of infants who are both wrapped and on thermal blankets and under radiant warmers who become hyperthermic. And although that represents a smaller number of infants, it certainly is a sincere balancing complication. So I'll end on that note and hand it back to you, Danielle, and our discussants, Dr. Fogli and Dr. Edwards. Thank you.
Thank you, Dr. SOLL, for that extensive and amazing evidence review. We have a few more polls to engage this fantastic audience of just over 600 logins and tailor our comments and conversation. The next poll question is a simple one, hopefully quick to answer. Do you know what the temperature is where you resuscitate preterm infants? So not necessarily do you have control over that temperature, but do you know where you're starting from? Do you know what that temperature is? So please click your answer on the Zoom polling platform and click submit. All right, so 70% know what that temperature is where they're starting from. So that's a great place to start, is knowing what that temperature is, knowing if it's within the range that's appropriate for keeping preterm infants warm. 23% are saying they don't actually know what the temperature is. So that might be an important thing to explore after this webinar and with your team. And for the 7%, they're not sure. Another opportunity to investigate and to have some team exploration together. Great, I'm glad we have this working. The next one is a little bit more of a deeper dive. So we had a fantastic evidence review by Dr. SOLL, and curious to hear what interventions your team is currently using. This one will give you a little bit longer because it's a complex one. It's a check all that apply. So of all of the different interventions that we now have a briefer on what the evidence is, which ones of these are you using in your practice in the delivery room to maintain normothermia for infants? Incubators, radiant warmers, thermal mattresses, the polyethylene bags or plastic wraps, hats or head coverings, increasing the room temperature, heated humidified gases, skin to skin care, or warmed IV fluids. So it looks like the vast majority, over 90%, are using three main things: radiant warmers, the polyethylene bags or plastic wraps, and hats. 3/4 of us also at times are using incubators or increasing the room temperature and the thermal mattresses. And then about half heated gases, skin to skin care, and just a small minority, about 13%, warmed IV fluids. So very interesting to put into context with that evidence Dr. Soll reviewed for us. Thank you for sharing that, and we'll take that into consideration as we get to our conversation with our discussants. I'd like to pass the microphone now over to my colleague, Dr. Erica Edwards, to share some insights on recent bond data and research. Over to you, Dr. Edwards.
Thank you. So I'm going to put a link in the chat to a NICU by the numbers that we did. It was our very first NICU by the numbers that we did. And we looked at temperature at a NICU admission. And at that time, we said that 4 in 10 infants were cold upon admission, meaning that they weren't in this green bar here of normothermia. I updated the numbers, and I'm pleased to say that it's now 3 in 10. So when our first look, as you can see from that web page, there were 43% of infants who were normothermic, and it's now up to 64%, which is fantastic. And there's obviously a great deal of quality improvement going on, as people have been discussing in the chat, as well as other effort, which I think is just fantastic. I do want to point out a manuscript that we produced, though, that was published in 2023. The lead author, Alejandra Fred Garcia, is a neonatologist in Mexico, and we were joined by colleagues from Brazil and South Africa, as well as Dr. Ann Hansen, who's a neonatologist in Boston. And we looked at the distribution of neonatal admission temperature by middle income and high income countries. The point of doing this analysis was to show that the problem of hypothermia, neonatal admission temperature and hypothermia on admission, is an issue for everyone. So on the left, we have hypothermia in the middle income countries that are members of BOND, where obviously there was more hypothermia, as shown by the blue bars on the chart. But there was still admission hypothermia by, in the various birth weight categories in the higher incomes as well. And as Dr. Soll pointed out, we had in the higher income countries, perhaps for hyperthermia, or infants who were too warm on admission compared to the middle income countries. So this issue of thermoregulation on admission to the NICU is an issue for everyone, and something that hopefully everyone is addressing regardless of their location. So I'll turn it back to you, Dr. Eric, for the next poll.
Thank you, Dr. Edwards. So we do have one last poll. This is our final one. And we're going to focus in on one particular intervention. So we're curious, now that we've heard a bit more about plastic wrap and the evidence behind it, for preterm infants specifically, do you use plastic wrap when you're doing the practice of delayed cord clamping? And we'd say whatever delayed cord clamping means at your institution. This is a single choice question, so either yes, no, or I'm not sure. All right, so about half have that practice in place. to be using delayed cord clamping with plastic wrap. 38% aren't doing that, and 14% are not sure. So maybe a reflection after this webinar, is that something that might be on the horizon for some of our teammates? All right, and now we do have another discussant. I'm very pleased to welcome Dr. Elizabeth Foglia with us, who's PI of the DRIVE Network and has a keen interest in the delivery room environment. So Dr. Foglia, I'd like to see if you have any comments on that last poll, and also to share some insights on improvement work on preventing hypothermia.
Thanks, Danielle, and thanks for having me today. Yeah, when the group at Vaughan asked me to speak today on hypothermia, I was reflecting about how this has really been a problem that has been on the mind of neonatal providers for over 100 years now. So even before Bill Silverman, if you are a reader of history, you might be aware of Pierre Boudin, who worked in Paris and started to examine outcomes and practices for preterm infants there and started to give lectures on the topic. And his first lecture from the nursling really focused on hypothermia and putting to point out to others in the field that without taking precautions to prevent hypothermia, weaklings, which is the unfortunate name they were using for preterm infants at the time, were subject to hypothermia. So in his lecture, he presents a preterm infant who became very cold, and despite the fact that the baby was placed in an incubator. And I think a key point that he made there is to say, listen, how far would this temperature have fallen had the measure not been taken? So the first of 3 points that I thought about when I was reflecting on all of the evidence that Roger presented is the point that Roger made at the end of his talk, which is, firstly, you can't improve what you don't measure. And so I think we've been given a lot of review today of the evidence behind multiple interventions that we have in our toolkit to prevent hypothermia. But probably one of the most important interventions that we need to also employ is the thermometer, and ensure that we're really keeping close track of our preterm infant's temperature throughout resuscitation. And as many have pointed out in the chat, not just on admission to NICU, but during that transition as we establish neonatal care in that new environment. And so at the patient level, I would really just urge us all to continue to measure and also respond to patient temperatures. Here I've demonstrated just one flowchart of how we've approached this at one of our perinatal hospitals. But I think the key point here is really twofold. One, ongoing measurement of temperature is key. And secondly, for those of us who are employing multiple interventions to maintain euthermia, there is a risk of hyperthermia. And so I think ongoing temperature control and ongoing temperature monitoring gives us an opportunity to continue to titrate the interventions that we're using and making sure that we're both preventing hypothermia and also not inadvertently causing hyperthermia. The second piece of measuring and data, I think, really fits at the unit level in terms of ongoing efforts to monitor and track admission temperatures. And my sense, as I thought about this session today, was that there really have been a number of quality improvement projects that have been published in the field over the last decade or so. And when I went to PubMed just to search what that looks like over time, it confirmed my suspicion. So this is just showing you the number of published articles focusing on quality improvement projects to prevent admission hypothermia. And I suspect there are many more quality improvement projects that have been conducted that haven't actually hit the PubMed yet. So all of this, I think, is a testament to the field's general focus on this, and maybe part of the reason that we're seeing some of the slow and gradual improvements that Dr. Edwards showed us with regards to reducing the number of preterm infants with hypothermia on admission. The second point that I wanted to make is that actually I think there are other newborn populations who are at risk for hypothermia apart from preterm infants. And specifically, I wanted to highlight newborns with congenital anomalies. I work at one hospital at CHOP. We have a very large volume of inborn infants with congenital anomalies. And when we started to systematically track our admission temperatures, we found, similar to the data we just saw from Vaughan, that about 3 in 10 were being admitted to our NICU with an admission temperature of less than 36.5. I think there are a number of risk factors at play here. For some of our patients who frequently experience extensive resuscitation, such as babies with CDH, that increased exposure might be at play. For some of our patients with external defects, such as omphalocele or gastroschisis, there's increased surface area, which also increases the risk for hypothermia. But again, I think this just is one opportunity to draw our collective attention to the fact that we have other high-risk populations at risk for hypothermia and for whom ongoing attention for thermoregulation is likely to be very important. And while the data that Roger presented today didn't specifically focus on these populations, I'm pleased to report that many of the interventions that we consistently use for our preterm infants are also quite effective at preventing hypothermia for this other population of babies with anomalies. Lauren Heimel is our nurse lead here at CHOP, who led a quality improvement project to employ multiple of the similar interventions, including environmental temperatures, increased use of hats, as well as more frequent temperature assessments and chemical matrices. And what you can see over time is that we have reduced the incidence of admission hypothermia among our infants with congenital anomalies using some of these tried and true techniques. And then the last point I'd like to make, and again, this follows on some of what Roger already alluded to, is that, I think from my perspective, thinking about the delivery room, we're in a fortunate position that we are consistently having new evidence that's informing our practice. And so the way that we manage and stabilize infants in the delivery room will continue to change. But as our practice evolves, we will also need to evolve our approach to thermoregulation to make sure that we're keeping track of this key measure during the delivery room. So on the left, I think there's already been some mention of delayed cord clamping. This has been a very nice evidence-based practice, and this is really the gold standard for how we should be approaching initial stabilization for preterm infants who don't need resuscitation. And I was heartened to see that so many people are already using wraps or thinking about thermoregulation during delayed cord clamping for preterm infants. On the right, there is a growing interest in a number of trials that have been studying the impact of physiologic-based cord clamping or cord clamping with an intact or resuscitation with an intact cord for those preterm infants who do need resuscitation immediately after birth. And this is, I think, an area of resuscitation science that's still evolving. I don't think we quite know yet as a science whether there's enough evidence that we should be adopting this as a uniform practice. But I do want to highlight it today just because I think as we think about starting to resuscitate at the perineum or at the field for a cesarean section, we probably do want to give close attention to thermoregulation in those unique environments. The largest trial of intact cord resuscitation that's been published to date was VENT-FIRST, which was published this summer. And VENT-FIRST studied 570 infants who were born preterm, and they compared ventilation before cord clamping at 120 seconds with a more traditional delayed cord clamping at 30 to 60 seconds, with a primary outcome of IVH or death at 7 days of life. In that trial, there were no differences between groups in the primary outcome or any of the major morbidities or mortality that were assessed. But the trialists did report increased risk of hypothermia among those infants in the intervention group who received intact cord resuscitation. So again, I think the field will continue to evolve. There are other large trials that we'll be reporting soon, but I just wanted to use this as an opportunity to really highlight the fact that new approaches to resuscitation will require new approaches to thermoregulation. And I think at that point, I've seen a lot of really nice commentary back and forth and through questions in the chat. And I think we'll spend the last minutes here opening this up to a discussion with the group. Thank you.
Perfect. Thank you, Liz. I invite Erica and Roger to turn cameras back on. What an amazing review, highlighting some hot off the press research and some wonderful QI projects happening. I think my first reflection on this topic is we as a community can do better. Like, we've known hypothermia for infants has been an issue for 100+ years. We know that there are interventions that can be helpful, even low cost, no cost interventions that can be helpful. So it gets my implementation science, hat thinking and QI hat thinking of, what do we need to do? So I'm curious to just open it up to the three of you. Any words of wisdom, of thoughts? I think that there's great interest in making, some nice strides. Erica showed we are getting better, but we want to get better faster. This community is a wonderful place to learn from each other. I've already learned some wonderful things from the chat today, but any comments that you'd like to share?
as I look through the chat, Danielle, one thing that really occurs to me is saying in delivery room care that if you've seen one delivery room, you've seen one delivery room. So although we're all reading similar textbooks and similar recommendations, the way that each hospital operationalizes delivery room care is very different and context specific. And I think especially when we think about thermoregulation, there are often going to be interested parties outside of the neonatal care providers, and engagement with those parties is paramount. So whether that's obstetrical providers when thinking about how hot or cold is a delivery room, thinking about hospital facilities with some of those environmental factors, I think this is one of those aspects of quality improvement that's really going to force providers to engage broadly. And in some cases, that's challenging because there may be elements at play that are outside of the control of the neonatal team specifically.
I would like to reiterate what Dr. Foglia said about you can't study what you don't measure. And I would actually I'm going to put another link in the chat to one of my favorite quality improvement studies on admission hypothermia. That's the link to the PubMed abstract, because they specifically said in the abstract, we reviewed our bond data and looked at comparable NICUs. And that's what Nightingale is all about. You can go and look. We've got both the categories, so normothermia, hyperthermia, but we've also got the actual temperature, so you can go and see a box plot to see, and then you can add comparison groups. How do I compare to these other NICUs of my same type or NICUs in my state, in case that's important. And the same is true for global health members in reports. So that would be a great starting point if you're interested in improving hypothermia.
So just to chime in, Liz, your point, each setting is so different. And the other deficiency in the evidence is that it sort of picks off one thing. None of us do one thing, right? And you mentioned that in your comments, Liz, that, we got caps on and mattresses and whatever. As a very concrete issue, I'm interested in the lack of use of the humidified gases. I did not discuss in our didactic session the network meta-analysis that was done, and I just put the reference in there. It gets very, very complicated, and it did show, as I noted, that many different interventions have helped improve temperature. But in terms of the network analysis and the rank order, they had humidified gas quite up there, right next to plastic wrap, as the two most important things we can do. And I'd be curious what you and Danielle think about the barriers to using that, whether that's a pressing issue that people should consider, or whether it's just one of the many things that we should all be considering in the system.
I'll go first and then love to hear Liz's thoughts. So Roger, I think that is an excellent point. We know that the curve of delivery room CPAP is skyrocketing. And so I think this really is something that we should be mindful of. To Liz's point, every delivery room looks different. So I think speaking with your respiratory therapists and facilities, what does that look like here? Is it feasible? Can we give it at the warmer or right next to mom, and then it stops, and then we start it again once we get to the NICU, and the transport in between, might be different. But I think figuring out if you can do it, what that looks like, is it feasible, is a fantastic thing for our teams to think about, especially knowing the rise of our use of CPAP in the delivery room.
Yeah, I guess what I'd add to that, or just my own reflections, I do think we have a number of tools in our toolkit. I think if you're a center that has already employed multiple interventions and your only goal is to target euthermia on admission, you may not see a role for heated humidified gases because perhaps you've already reached appropriate numbers. What that means to you is of, euthermia on admission using potentially some lower cost interventions. But I would also take note to what someone wrote in the chat. There may be other benefits to heated humidified gases, pulmonary function, et cetera. So little hard to know. I take your point also, Roger, that I think many of the trials make it challenging because they're studying single interventions in isolation, and many of us are bundling care. But I think the heated humidified gases are probably something that have received a little bit less attention, especially on this side of the Atlantic, with regards to what role that might have in delivery room care.
And the chat has pointed out that that's also a resource issue, no doubt,
Yes.
and may not therefore be first on many people's lists. I bring it up because it was one of the good therapies that was a bit of a loser in our poll.
Liz, I was curious, there was a question from the chat thinking about not just the delivery room environment itself, but that early stabilization period, which includes some of the admission procedures, placing lines, and really thinking about the golden hour. You alluded to many of the interventions we use in the delivery room for preterm infants also work for patients with congenital anomalies. Any thoughts on our approach to procedures and that stabilization? Should we think about those similar to the delivery room environment?
Yeah, I think one interesting concept is, what is the delivery room? And I think for many of us, again, that practice looks very different. I've been to many centers where their goal is to stabilize very quickly and get to a NICU, and they might continue what would be performed in a delivery room in a different center. So I think if we broaden that concept to not be one physical environment, but more to think about the early hours of life and all of the interventions required to stabilize a patient, whether that's a preterm infant or a high-risk baby with anomalies. I think places where I've seen a lot of success are where they really consider this one continuum and think about how are we going to transition from, you know, the birthing parent to maybe there's a stabilization suite to the NICU. Some of the interventions I've seen that are quite successful are starting that resuscitation in an isolette that remains the patient's isolette. For us locally, we found that we were having probably a lot of heat loss in transit. We were collecting temperatures in the delivery room before we left, and that looked good. And then by the time we reached the NICU, the babies were already cold. So thinking about those transition zones, I think, is probably important. And then I think also thinking about some hands-off time for the baby. So trying to bundle care and bundle those initial assessments and procedures so that you really do have an opportunity. We're probably singing the same song multiple times, but I think a lot of this comes back to just ongoing close attention to the temperature so that you know in your setting and the way that you've operationalized things, where are those high-risk transition periods? And that might give you some clues as to how to streamline the process a bit more.
That's been only a marginally studied major risk. We talk a lot about the setting of delivery and not about that transition. And no doubt there's huge risk there. So that's a great point, Liz. Thank you.
Absolutely. Well, the hour just always flies by. We're already at the top of it. So I want to make sure everyone is able to get their continuing education credits. You can scan the QR code or use this link. 1 hour for participating in today's session together. We really appreciate